I'd like to introduce you to our Health Equity Leadership Commission. And their bio sketches are in your folders, and as I call their names, I'd like them to come up. So you've already met Mr. Daniel Dawes from Premier Healthcare Alliance. Dr. Willarda Edwards has joined us, immediate past president of the National Medical Association, and I know that Britt and the rest of the staff is going to make sure that we have enough chairs up here. Ms. Millicent Gorham from the National Black Nurses Association. Mr. Peter Hebert, Winston and Strawn. I saw Peter come in. Dr. Tom Leviste, professor and director of the Center for Health Disparities Solutions at the Johns Hopkins Bloomberg School of Public Health, and the William C. and Nancy F. Richardson Professor in Health Policy. Dr. Marjorie Innocent, oh, she is here. I know Marjorie's so busy since this is a foundation function, but I'm so glad she's here, from the Congressional Black Caucus Foundation. Mr. Bruce Leslie, First Focus. Come on up, Chris. You don't have to wait. Mr. Chris Porter from Novo Nordisk. Ms. Mila Moss, the American Dental Education Association. Ms. Makani Temba Nixon from the Praxis Project. Ms. Fredette West. Do we have enough chairs up here? We don't. And I don't have to. I'm not going to sit again. Okay. And Ms. Mara Yodelman from the National Health Law Program. Now, we've already had one meeting, and I want you to begin by giving these folks a warm round of applause for being willing to step up and take on the responsibility on your behalf of monitoring the implementation and guiding the implementation of healthcare reform.
Come on up. I'm in the back.
So how we do it? But I'm not going to sit down. I'm not going to sit down, so I don't need a chair.
No. I know my place. I'm going to join you.
I'm going to begin by asking questions, a few questions, and we want the audience to be prepared. We want to make this pretty much interactive because you have the broad view. Are there any questions that are immediately come to mind for the panel? Does anyone? Oh. I'm going to start with a few questions then. And I'll direct them directly to each panelist. I'd like you not to take more than maybe 2 minutes to answer the question. And then as we go along,
I thought it was on front.
I don't mind being interrupted by the audience for a question. So let me start with Ms. Temba Nixon from the Praxis Project. There's been a lot of discussion, and Dr. Ruffin spoke directly to it, to addressing the social determinants as part of a comprehensive strategy for health equity. What are some of the opportunities that you see for addressing social determinants in the health care reform bills?
Good morning, and thank you. I really appreciate it. I'll be brief since there's so many of us here. Can you hear me without the mic? Can I project?
Yeah, they're going to turn on the mic for you.
We're good? All right. That's it?
So go ahead and start. They'll figure it out. Any other mic on? Sure. Turn on any of them and we'll move it around.
Can
I get a chance to compose myself? Where's the handheld mic? That's okay. Ooh, there we go.
Okay.
Good morning. Oh, he's bringing it to me? Oh, that was the mic from afar.
Where is it? I think the one on the end is working. Go ahead.
Thank you. Good morning, and thank you to Representative Christensen once again for bringing us together and helping us think about all of the really important cutting-edge health issues that affect our communities. I'm just so grateful. Just be brief, I think that we really have unique and wonderful opportunities, really for the first time, to really make social determinants the scientific and evidentiary base that we know works in terms of prevention, in terms of addressing disparities, all of those issues, to really bring it together through the healthcare reform bill, in addition to, of course, a number of other legislation that's passed that starts to address this connection between housing and jobs and health. So I think in prevention, for example, there are a number of funding initiatives that many of you are familiar with in terms of the transformation grants. There's also the ways in which many of the work is defined in terms of what constitutes prevention. We have the most broadest definition in the legislation that we've ever had. And not to get into details, because I don't want to belabor the point and make sure that people get a chance to talk, but I think that even though we have these opportunities, both in terms of defining and addressing this nexus between health and other social issues, we also have to be vigilant around defining what it means and who has the capacity, or really who's qualified to engage in this kind of work, this prevention work. Ooh, I'm getting loud.
I believe the other one is on now.
I think this mic's on. Okay,
Yeah.
so I'm going to turn this off.
Or pass it to the back and we'll
There we go.
Yeah. So when I get to the questions,
Somebody,
somebody
Tom, take it. Thank you. So just to close, I think that one of the things we have to do is do a clear job of defining what is a community-based institution that can engage in social determinants work. Engage in the social determinants work. So that we want to ensure that the resources and the funding to engage in this kind of advocacy, to engage in this kind of housing policy, actually gets to community groups and not to some of the, to the larger sort of, I will say, usual suspects. So again, we have to do a good job of defining what constitutes a community-based group, what kind of connections and track record do they have to have, how do we help through the implementation, develop pathways for collaboration between DHHS, housing and other parts of government to make those social determinants work real, and then how do we monitor and watch the funding to ensure that we actually improve the infrastructure, the housing infrastructure, the jobs infrastructure, as part of an indicator of what it means to improve health status.
Thank you. Chris Porter from Nova Nordisk. As you know, prevention scoring is in dire need of an overhaul. Can you just briefly speak to that issue and its importance, not only in the health policy making process, but to health equity, and some evidence that you may have seen that suggests that prevention scoring goes way beyond the 10-year window, and how that could have perhaps allowed us to do more within the building?
Absolutely, Congresswoman. Thank you. Probably one of the biggest kept secrets in D.C. is the power of the Congressional Budget Office and the sway that it has over initiatives in Congress. And unfortunately, there are so many bills, preventive health legislation, that is designed to address community-based preventive services and care, things that can really make a dramatic difference in the quality of people's lives, gets stopped cold in its track by kind of outdated scoring methodologies at what's called the Congressional Budget Office. So before any bill comes to the floor, the Congressional Budget Office has to give it its stamp. And last year, two really good things happened. One is that there was a peer-reviewed article that had Bush people on it and Clinton people on it and everybody in the world that said, hey, this is really a bad idea to keep going the way we're going, and that we need to try to look at how these bills affect people, how it affects their disease progression, because so many of these chronic diseases are just wiping out entire communities, and Congress can't pass the bills that they need to pass because of this outdated kind of thinking. So the other great thing that happened was that you got together with the Republicans, so this is not you know, this is not something that's just on one side of the aisle, is that there's a bipartisan initiative in Congress to change that, and not to tell CBO what to do, but to say, hey, if you're going to score legislation and you're going to say how much it costs, you've got to count how much it saves to, and to use and look at how it affects diseases at the community level. And it's a big kept secret, but if people can start talking about it more and talk to their members of Congress, we might be able to get some of these bills passed. The other thing is that there's even more at stake now, because there's $15 billion in a trust fund that's out there, and there's going to be lots of programs that are being done at the community level, and if we don't have good scoring to try to figure out the costs and benefits, all that good work might go to waste.
Yeah, the big limiting factor for us going through this process was cost. For example, we couldn't get dental into the basic package for adults. Cost. Territories, shortchanged, cost. So we really need to be advocates for scoring, prevention, and using that money, even going forward as we are able to monitor and find out where those savings have occurred, and then apply them to some of the things that we could not get done in this year. Let me go to Dr. Edwards. One of the big challenges is going to be meeting the healthcare workforce demands. And how do you see, how does the National Medical Association, I know you had a conference, your convention recently, have you discussed it? Have you seen ways that we can really jumpstart that process and develop a clear pipeline for our young people to enter the health professions?
Sure. One of the things that we've been mainly concerned about at the National Medical Association is the workforce when it comes down to healthcare disparity and the diversification of the workforce. Whether you're talking about physicians or those in the other health professions that be in the nursing physicians, assistants, and nursing nurse practitioners, thank you. Also, we very much indicate the need for working together with our mental health professionals as well as the dental, and that's all part of good medical care. When we look at the diversification of the workforce, one of the things that people have emphasized is the fact that we need more primary care. In the National Medical Association, we did a survey of our physicians. This was just a recent survey about our journal. And what I came away with was the fact that a large percentage of our National Medical Association members are in primary care. And when I looked at the statistics, this was just of those folks that responded to our journal issue. And that was that 17% were internal medicine, 16% family medicine, 14% in OB, and 11% in pediatrics. And a good percentage of 10% to 7% in surgery or psychiatry. But when you look at the other subspecialties where we also need help, less than 5% were in areas such as anesthesiology, allergy, dermatology, plastic surgery, pathology, radiology, and other specialty areas like ENT and orthopedics. So we know that there needs to be a lot more in terms of primary care, but we also need diversification in the specialty areas in the minority community in particular. So that all adds up to our addressing the whole issue of health disparity, not just the issue of workforce, but clearly we need to improve the overall numbers because our numbers in terms of the greater population of physicians is less than 10% are minorities, whether you're talking about Hispanic, African American, Native American, et cetera. And so when you look at the larger majority of physician population, we still need to make sure that there's an issue of cultural competence is being addressed by all physicians, even those of color. We all need some cultural competency training on an ongoing basis. And then, of course, we need to address the whole issue of the other health disparities that really affect our community, whether you're talking about diabetes, HIV, AIDS, cancer, cardiovascular disease, and infant mortality. And that's what the NMA is definitely focused on and moving forward with collaboratively with all the healthcare professionals and also the AMA physicians.
Thank you. Do I have any audience questions? You have one? Okay, I'm going to ask the next question, and while they bring you a mic. Mr. Leslie from First Focus, there are some areas that are that your organization has already begun to focus on, and which will be very helpful to the process of monitoring the implementation. Could you
Sure, absolutely.
tell us a couple of them?
Thank you, Congresswoman. And a couple of things that are really important to children in the health reform package that Congresswoman Christensen and her fantastic staff person, Britt Weinstock, really helped us with were first and foremost is for kids, the uninsured, the majority of kids are actually eligible but not enrolled. And so one of the issues we worked really closely with your office and you on was the outreach enrollment, express lane provisions. One of the problems for families certainly is we know by definition of family who is eligible for Head Start or WIC or the school lunch program, they are clearly automatically eligible for Medicaid or CHIP, and the fact that the government has asked people to come in and prove again and again and again their eligibility. And so one of the issues we really worked on and got in the bill was this concept of express lane coverage and coordinated enrollment, so that when you prove once, then you should be automatically enrolled. Other things, and certainly, are the health disparity provisions in the bill. So there's language in the bill that Dennis spoke to earlier on oral health, and Congresswoman worked really hard on, and asthma, childhood obesity, and a personal issue for me is infant mortality. And then in addition to that, I think that one of the things that was really shocking to us during the conversation is the assault on Medicaid, the Medicaid program and the Children's Health Insurance Program, but particularly Medicaid. You can look in the congressional record and do a search on Medicaid, and just this constant barrage of attacks on the program. And the program will be covering, already covers 20 million children, but that will increase with the passage of the law. And so one of the initiatives we're really working on with the Congresswoman and others is kind of improving and defending the program from attacks. Just this past week in Nebraska, the governor of Nebraska tried to force the education and pit the education and health communities against one another, and said, if you don't, to the education community, if you don't support cutting Medicaid, then I'm going to cut your education budget. And it was really trying to create, and back to the Congresswoman's first question, kids need education and health to be successful in life, and we should not allow this pitting of programs against one another.
Thank you. First question from the audience.
Good morning. I'm Livonia Allison from Durham, North Carolina, but I spent about 15 years trying to increase minority presence in the health professions with a North Carolina HCOP. My concern and my question deals with increasing the representation of minorities. The word minority has changed its complexion. The pie has gotten smaller. And it's really wonderful now to be a minority, to get a piece of the pie. And one of the things I want to understand is how will we begin to talk about underrepresented minorities and minorities who will go into underserved communities. And I'm concerned that we cannot start, when we first started having programs, it was at the college level. When will we get an opportunity? The first beginning, when you hit the 6th grade and you have to select whether you're going to take algebra, whether you're going to take those 04 sciences, biology, chemistry, physics, algebra. And unless we can understand the disparity right now in terms of African Americans and Native Americans and Latino Americans, the other big representation of minority now, some of them are overrepresented, and I'm sure you all know the minority that I'm talking about. Okay, so we've got a connection between the elementary, the medical school, the professional school, and some summer programs to deal with these kids starting at the 6th grade, 7th grade, 8th grade. That should have searched, because I don't have time to ask that one.
Well, we might get. I'm going to let Millicent Gorham from the National Black Nurses Association begin to answer the question, and maybe Dr. Bullard Edwards may piggyback.
Thank you, and thank you, Livonia, who's been coming to these Congressional Black Caucus meetings for at least 30 years now. 40, okay.
It's been around 40 years.
And she's always been very concerned about the pipeline. I think in terms of that pipeline, yes, we do need to look at getting these younger, these students from actually starting K through 12 to really look at the health sciences with all of the math that's required, the reading, the writing, the whole gamut. From the biological sciences through chemistry, and having those enrichment programs as well. I just want to throw out something that our president, Dr. Deborah Toney, will be launching at the National Black Nurses Association's conference this year, like NMA, a program for our potential nursing students. And what she's launching this year is for students from 8 years old to 16-year-olds, to have a 2-day session at our conference on what nursing is all about, and taking them over to a hospital, taking them to a research facility so that they can begin to really understand what it takes to become a nurse. And a nurse from that BSN prepared to postdoctoral nurse. So we are looking at those pipeline issues. And we're not just, have collaborations with other organizations like the National Hispanic Nurses Association, like the Philippine nurses, Native American. So that whole pipeline issue, we're collaborating with other organizations so that they'll be able, that we all can collaborate and look at those issues together.
Dr. Edwards.
And I would just very briefly say that the National Medical Association has been working with a program that we call Doctors Back to School, and this is in collaboration with the AMA. And we recognize, the NMA recognized that you don't start in high school, you don't start in college. You need to go back to middle school, and as we've already heard, as young as you can get them. So we have been doing this program on a regular basis as a part of the Commission to End Health Disparity, and then it's been incorporated in our activities every time that we have a meeting with the AMA or a meeting with the National Medical Association. And so we realize that we need to start early, and we're doing it in conjunction with all the ethnic medical associations, and we've included also the nursing, the dental, the mental health professionals as well. So it's not just about trying to get them into being a doctor.
And I believe that even in ARRA, the Recovery and Reinvestment Act, there was increased funding for HCOP, and there's some great programs like the Physician Scientist Training Program that we really need to support and expand on. It really starts at 6th grade and reaches all of the underrepresented minorities, but there's specific language in the bill that speaks to increasing underrepresented minorities, and part of all of our work is to make sure that we really do the outreach that's necessary as far back as necessary. Myla Moss from the Dental Education.
The American Dental Education Association, representing 61 dental schools and 700 dental residency training programs, was successful in securing a grant with the Robert Wood Johnson Foundation. And over the last 10 years, we've instituted a program known as Pipeline Profession and Practice. And this program is designed to recruit underrepresented minorities to serve an underserved underserved populations. Excuse me. And we've had 15 dental schools participate in this program. $19 million was allotted. An additional $4 million was given by RWJ, and it's been quite successful. We've seen an increased number in underrepresented minority applicants, with a 30% increase in African American applicants and 22% increase in Hispanic applicants.
Great. Daniel, you get 30 seconds.
30 seconds, okay. So just wanted to piggyback on what the Congresswoman had said about those provisions in the law around increasing diversity. And one of the things that happened during the negotiations was the U.S. Commission on Civil Rights had actually promulgated letters. They had done some messaging around the whole language, especially in the House bill at the time, but also with the Senate, saying that this was a violation of the Constitution and it was a violation of the Supreme Court's precedent on affirmative action in 2003. And we basically pushed back and said, absolutely not. It doesn't do that. So that's one thing that you're going to see coming up again, I think, as implementation rolls on. Look out for that, that argument.
Okay, and the other thing, there are a number of task force and commissions that have been developed in the law, and one of them addresses workforce, and we have strongly, as a Tri-Caucus, recommended that Secretary Sullivan sit on that task force to make sure that we have a voice that begins to address some of our issues. Okay, good.
I'll be real quick. Fredette West with the Racial and Ethnic Health Disparities Coalition and African American Health Alliance. But based on what you just said, what we will do, I don't know if it already exists, but we'll call for a partnership between the National Institutes of Health, the Department of Education, and the National Science Foundation. Because as you pointed out, over the years we've talked about it, pushed on it. Now in this opportunity of achievement, that's where we do need to be and make sure they do it. And there are people like you out there that know how to help make them do it.
Great, great, great. That's a great, so that's something that you said that we're going to take on? And we'll be backing you. The commission will be backing that. Thank you. Ms. Yodelman, you and your organization have done extraordinary work around linguistic services and the importance of ensuring that such services are within and throughout the healthcare system. Could you share with the audience what is currently in the Patient Protection and Affordable Care Act, what's missing, what are some of the things that are there, what do we still need to work on?
Sure. We actually worked with your office and the Tri-Caucuses, and a number of the things that are missing because they were in the House bill but didn't unfortunately make it into the final Senate bill that was the one that became the basis of what health reform law now is. We'd love to see for language access a real recognition that Medicare should be paying for and providing language services, and it doesn't. Yes. We've been able to get some increased funding in Medicaid to pay for language services for children, and it didn't follow through to increase the federal payments for language services for adults in Medicaid. And we didn't see explicit provisions for many of the private insurance provisions that are in the law. And that's really unfortunate. When we create these new exchanges, when we have new demonstration programs, et cetera, there's very little explicit language, but there are lots of opportunities. And I think we have to explore those and really seek those out. One of the most important provisions, I'd say, in the health reform law that we all can use as sort of an underlying basis for expanding language access, expanding work on healthcare disparities, expanding data collection, is the non-discrimination provision. And if you're not familiar with this, you should become familiar with this. It's a provision that prohibits the discrimination on the basis of race, color, and national origin. And we get to language by national origin for any federally funded program, any new entity created by the health reform law, so all of the exchanges, and also for any program or activity administered by a federal agency. So it has broad scope and great opportunities for us really to ensure that health plans, health insurers, and others that are created and coordinated through health exchanges and the law aren't discriminating, but we need to make sure it's implemented correctly. And the Office for Civil Rights is taking the lead at writing the regulations to implement that, but we also need to look at all of the other regulations and policies and demonstration programs and grant programs to come out to make sure that the way that they're written addresses the needs of our communities, that data is collected, that funding is provided to evaluate data so you know if there are disparities among different racial, ethnic, or language groups, and that funding is included in all of these programs for language services. So while we didn't get as explicit language as we would have liked, there are great opportunities. We need to take advantage of all of them and make sure we really work to implement this in the fullest as we move forward. So I thank you for your work on this and also look forward to working with the Commission and the Tri-Caucuses and the CBC as well to really make sure we can move this forward as much as possible.
Thank you. Is there a question from the audience? Okay, I'm going to ask the next question and then we'll come back to you. Dr. Leviste and Dr. Innocent, as health services researchers, as well as providers, and educators. What are some of the emerging health equity trends that you're seeing now, and how can researchers play a role in ensuring the full implementation of the health equity provisions in healthcare? What are some of the research topics that we think should be explored to provide advocates and lawmakers with reliable and valid evidence they need to build a case in defense of these provisions?
Well, there's so many ways to go with that question.
I hear you.
So a couple of thoughts come to mind. On that.
Yes.
A couple of thoughts, yeah, it was kind of
I think so.
a voice out of nowhere, right? A couple of thoughts come to mind on that question. I'm going to just sort of respond in no particular order. But one of the concerns that I have in particular, which is really, I think, more out of the ARA bill, but is very much related to all of this, is the e-health and the implementation of the electronic health records and meaningful use. So how do we define meaningful use in a way that it is meaningful to culturally diverse populations, and how do we ensure that that technology is available to practitioners that are practicing in, let's say, communities that may be not as interesting to large vendors producing this technology who want to make big sales. Right. So I think there's the potential to have a real diffusion of innovation problem where we'll diffuse this innovation, which I think will be good for overall population health, but if it's diffused in a way that it's not evenly distributed to communities that are predominantly minority communities, we may actually have a widening of the health gap. And I think that's something that we need to watch closely as researchers, whether or not we have the potential of the unintended consequence of creating, I guess, what we can call e-health deserts. In other words, communities where that won't have access to that technology, which has a great potential to improve population health.
Yeah, we've made that point at several of the hearings. You know, we're supposed to be reducing and eliminating disparities, not creating more, and that unless we address that we can't reach all of our communities with the full benefits of healthcare reform. And you might address also, as you answer, the education of the point that Garth Graham made over and over again about getting the information out.
That is correct. Before I talk about that, I think another critical point that really connects to what Tom was just talking about is the opportunity to be able to enhance current research by using data that are now going to become available, because it's going to become mandated for data to be recorded by race, ethnicity, sex, disability status, and language. And that's actually been a very critical limitation that a lot of researchers have had with their ability to really explain fully what health disparities are and where they actually exist. And so to make sure, number one, that that's actually happening, the data collection is actually happening consistently across all programs and throughout the entire healthcare experience, not just when a person first walks into a clinic, but then when we also track what kind of care they're receiving, where they're receiving that care, the challenges that they're experiencing with the medical establishment will also be a very, very important piece with that. And along the lines of education, like the Congresswoman was just mentioning, it's also going to become very critical for us to help the broader community to understand what exactly is in the legislation, what the benefits are that will actually be available to them, and then how best to use them so that they will really be able to tap into them to enhance their healthcare outcomes as much as possible. And towards that end, I want to mention that one of the goals that the foundation, the Congressional Black Caucus Foundation, has actively been working on, in addition to helping to organize this conference right now, is a community guide on the healthcare legislation that I'm very pleased to say is actually being co-authored by Daniel Dawes and Dr. Nicole Jarrett of the Cobb Institute at the National Medical Association. And this guide is really going to be designed for the broader population, really to break down some of the key provisions that are focused around health equity, helping people to frame the discussion, if you will, about understanding the challenges that African Americans experience within the health care system as being impactful on their overall lives, and really making a difference on the healthcare outcome differences that we're seeing. So we're really looking forward to having that come out over the next couple of weeks. And obviously with all of us here and everyone on the panel, it's also going to be very, very critical to help to break down what the legislation is really about for people.
Thank you, and may I pass the mic to you for your question?
Yes, good morning. My name is Reverend Yvonne Washington Teray, but I'm also a board-certified family nurse practitioner. And my concern is with the workforce and being in the workforce and having been in healthcare for more than 25 years. I believe that as a nurse practitioner that we could be better utilized in many areas. Our education is with the medical model, but we do very good jobs with prevention and in community-based areas where there's not really a lot of very big physician work pool. I think that nurse practitioners can be utilized in pools to help with a lot of the preventive medicine. So what I would like to know is what is the committee doing to encourage nurse practitioners as well as physician assistants in the expanded role where they can work more autonomously to help provide the health care that our citizens need.
Can you answer that? Okay.
Okay, so you know I'm in love with the Reverend, right? Thank you so much for asking that question. One of the great provisions in the new act is that there are going to be nurse-led, nurse-managed clinics. So that means nurse practitioners can go out there and get money. There's $50 million in the act. From my understanding, that will only allow for 10 nurse-managed clinics over the next 5 years to be developed and then implemented. So the nurses can go out there, hang out their shingle, bring in more nurse practitioners to work with them, an opportunity for more nurses to work with the nurse practitioners to provide the primary care that's going to be needed for this additional 35 to 50 million uninsured that are going to be flooding our healthcare system, along with all the baby boomers that are going to be flooding our healthcare system. As of next year, those that were born in 1944 who are going to be flooding our healthcare system and are going to need primary care services. So yes, and I think also along with that is working with the National Health Service Corps so that we can get more nurses educated through National Health Service Corps dollars, that they'll have loan repayments back into their communities. They'll be able to go back into their communities to provide those preventive care services that you're talking about. They'll be able to get their obligation from the National Health Service Corps taken away because they're providing that care in a HPSA. And so that's another opportunity. There's $1.5 billion is being given to increase money for community health centers. Now, we love community health centers, and we have nurse practitioners, nurses, primary care providers practicing in those communities where there are community health centers. You build the community health centers, you need to have primary care providers put there. So there has to be money for those nurse practitioners to be educated and trained and then eventually placed in those settings as well.
Thank you. Did you want to? Just pass.
In addition to what Millicent mentioned, another area where we have actually seen the critical impact of nurse practitioners is also within the realm of school-based health centers. For a lot of these centers, really, nurse practitioners wind up being the primary source of care for the young people who are able to get care, who are fortunate enough to, who live in underserved communities and can have a center in their school. There's increased funding within the legislation to be able to expand the number of centers, but also to increase the capacity of services that they provide. And so the ability for nurse practitioners to play a leading role, an even greater role, in helping to connect young people with care, and again, especially primary care, to be able to keep them healthy for those who have disease, to help them to be able to manage disease while they are in school, is also going to be very, very important.
And if I can just say one other thing regarding nurse practitioners, there there's a need for 1 million new nurses by 2020. We've got to try to expand, and as said earlier, expand the workforce, the diversified workforce. When you're talking about nurse practitioners, that means an extra 2 years and then certified beyond that, depending on their specialty. Just in the state of Michigan, one of the results we've heard earlier from the dean of Wayne State University in Detroit, she said just in Michigan alone, they need 2,600 new nurse practitioners just to take care of the state's needs right now. She's advocating for $5.5 million to train 100 of them. You do the math. How many more we're going to need just for the state of Michigan, let alone some of the other states like New York and Texas, Illinois, Florida, California that already have a major influx of uninsured uninsured people who are going to need these primary care services.
Like nursing, dentistry is seeing a drought in faculty, in mid-level providers, et cetera. And the Affordable Care Act authorizes $15 million for 5-year demonstration projects to study alternative oral health workforce, so that there is a hygienist and a oral health care coordinator at the front lines as a preventive measure, and to link the mid-level provider with a practitioner so that more access is provided.
Thank you. Thank you. In the audience, we can get ready for another question. I'm going to direct the next question to Attorney Peter Hebert, who works with our government in the U.S. Virgin Islands and has also done some work with Puerto Rico. And one of the most difficult provisions that the Tri-Caucus worked on was making sure that the territories, if they didn't get state-like treatment, which we did not quite get to, did get a great increase in funding for Medicaid and some funding for the exchange. Can you speak to some of the territorial issues?
Sure. Thank you very much, Congresswoman. There was some discussion earlier in the session about the non-discrimination provisions in the Act. You can't discriminate on the basis of race, gender, language, ethnicity. There is one area where there is lawful discrimination in federal health care policy, and that's whether or not you live in a U.S. territory. If you're a low-income person or uninsured in a territory, you don't have the same rights as if you were living anywhere else on the U.S. mainland. Medicaid. Medicaid in the United States, in any state, if you meet a certain income level or threshold, you're entitled. It's an entitlement. You have a right. If you live in a United States territory, it's a cap program. There may not be money to provide you the care that you would otherwise get or have access to if you lived on the U.S. mainland. Under the Health Care Act, if you're uninsured and you're above the new thresholds for Medicaid, the Act will make sure that you have access to health care. In fact, you will have a responsibility to have health care. The Act will provide subsidies, federal subsidies, to make sure that it's affordable. If you live in a United States territory, you may have access to some benefits, but it will be a fraction of the benefits that you would be eligible for and entitled to if you lived on the U.S. mainland. The Act made, notwithstanding this, a huge step forward in terms of bridging the gap between health care for U.S. citizens on the mainland and health care for U.S. citizens in the territories. The House bill in particular made a major move towards equality. Unfortunately, we all know how healthcare ultimately got enacted. We started with the Senate bill. There were modest improvements made to that bill through the reconciliation process. The fact of the matter is that the largest increase in federal funding for the territories was made possible by this act. So, what does that leave for the future? We made a major step forward. We're not there. We don't have equality yet, but there will be lots of opportunities to work with HHS, to work with the Secretary, and also to work with the Congress to build on the progress that was made, to build on the improvements that were included in the bill, so that our hope is at the end of the reform period, we will be close, if not all the way, to parity with the rest of the United States.
Thank you. Is there a question from the audience? Is there a question from the audience you'd like to get ready while I ask the next question? I will ask the next one and then we'll come to you. Dr. Smedley, I was looking through my notes. I'm trying to remember what were some of the issues that you raised at the first meeting. I have a note here that says, how do we redefine quality of care and cultural competency? Was that one of the issues that you raised? And I know you do a lot of work with Place Matters, and Dr. Ruffin mentioned the interagency collaboration around health disparities. Could you maybe speak to those two issues for me?
Sure. Thank you, Congresswoman. Happy to speak to those. You know, the Affordable Care Act offers a number of provisions, as my colleagues have said, that are going to advance the ball on equity issues. But some of the things that are happening have been happening even before the act was signed into law. So importantly, a number of federal agencies are collaborating because they're beginning to understand that you can't move the needle on health equity solely by looking at what happens within the four walls of the clinic. You've got to look at what's happening in communities. So we see some important efforts to collaborate between the Department of Health and Human Services, Department of Housing and Urban Development, the Environmental Protection Agency, the Department of Transportation. The basic idea is this: policies that are enacted in these other agencies have health consequences. And in particular, they have tremendous potential to either widen or close racial and ethnic gaps. Let's just take, for example, the Department of Agriculture. As many of you know, Department of Agriculture runs a number of food assistance programs. There is a food crisis in many communities across the United States that sets the stage for health inequities. Let me give you an example. I'm originally from Detroit, Michigan. Does anybody know how many grocery stores there are within the city limits of Detroit? One, Ruth? Is that right? No, it's zero. Zero. There are no major grocery stores or supermarkets within the city of Detroit. Amazing. Now, if you know Detroit, Detroit is a motor city, right? There's no public transportation because everybody's supposed to have a car. If you don't have a car, if you don't have reliable personal transportation, you're not getting out to the suburbs to get fresh fruits and vegetables. What you're stuck with is Burger King, Taco Bell, or whatever the little corner grocery is selling in addition to fried pork rinds, that kind of thing. So these are the issues that we need to begin to tackle. So we attempt to do this, obviously, at the Joint Center through our initiative called Place Matters, which is about building the capacity of community leaders to identify and address social and economic conditions in neighborhoods that shape health. Some of our Baltimore Place Matters team members are here. Thank you for joining us, Ryan and Shannon. You know, it's important that we focus on building the capacity of communities to drive the agenda around health equity. And as we think about the steps that need to be taken going forward, let's not lose sight of the fact that a lot of the action is local around decisions like land use, transportation, housing, education. These are the factors that set the stage for health inequities to begin with. So I'm very happy to see both increased federal attention to these issues as well as local attention, because we need not only federal leadership but also local leadership to tackle some of these challenges. So these are some of the issues. Congressman, you also mentioned the issues of quality. It's very important to note that many of the quality improvement measures will have as as part of the outcomes being assessed, the issue of disparities. So are we narrowing gaps in access to care and the quality of care? And these will be important quality improvement efforts. Part of the need is to better align healthcare resources with community need. And I think the Affordable Care Act makes an important step forward toward doing that by, for example, increasing investments in community health centers, increasing incentives for providers to work in medically underserved communities. These are some of the things that are going to begin to make a difference in improving access to care and also addressing quality gaps.
That lead these programs, that lead in these hospitals, that lead in these assisted living facilities. And this is where we end up having issues in our workforce in the health field with communication breakdown, with all kind of issues around cultural issues, with every issue you can think of. So what can we do to increase management and vice presidents and VPOs and such in this field of medicine?
Anyone on the panel is welcome to answer. Is there anyone from NAHASI in here, from the National Association of Black Health Executives? Okay. No.
That's an observation that I've made as well when I talked about what are the numbers in terms of physicians in the healthcare workforce are. One of the areas that was less than 5%, it's another section that the National Medical Association has in their, among all their specialty areas, and that is medical administration. That's less than 5% as well.
I thought it was about 2%.
It's about, I said less than 5%. It's probably about 2%.
It's low.
And
very low.
One of the things that we've encouraged people to do is maybe not the healthcare workforce, the organization you spoke of, Congresswoman, but encourage people to be a part of the American College of Physician Executives. That's at least for physicians, but we clearly need to have in all the healthcare disciplines more representation in administration. Totally agree with you on that, because that's where the rubber meets the road and decisions are made, as you said.
Go ahead, Tanya.
You know, I also want to say I completely agree. One of the real crises, though, is that for for every single one of the diversity issues we have, the primary breakdown is at the K through 12 level. That's where we lose. That's 80% of the problem. And so part of the challenge is how do we work together in a coordinated way to really require and move a quality schools agenda. You know, I mean, a lot of this, the K through 12 work is experimentation, even though we know what works in our communities. What we get are pilot projects or things that basically have very poor performance rates, even though the data says something, you know, what we ought to do, I should say, is very clear. It's a matter of money, it's a matter of practice, and it's also a matter of us coming together as health folks and really understanding that this K through 12 issue it's the pipeline to college. And of course, the rules around college is shifting dramatically to keep many of our folks out, even if they have the GPA. We have testing issues. We have a number of things that stop people before they can even start on the pathway, as well as the blocking of folks moving from community college into four-year and graduate schools because of the new scoring criteria. So I think that as important as programs are at the graduate level and at the post-secondary level, there's so much work we have to do at the K through 12 level to address this problem at the core.
Just quickly.
And for that, when you finish answering this question, would you just speak to the importance of the Office of Minority Health and the Institute too?
Yes.
Also.
Excuse me. And you may ask, why does she have on that pink hat? Well, this is my 5-year breast cancer survivor. And it is all of what healthcare reform is about. Early detection, complete treatment. When you don't have quality, search for that quality and follow up, because a lot didn't make it. In terms of the question that was just asked, we have to look at where we spend our money and ask ourselves in terms of who do we need to boycott. Because you're asking about that pipeline of people that have already been trained, already exist, have done the things we said they should do. Graduate school, do this, do that, volunteer, do this, do that. Now, yes, we have a pipeline problem, but we also have a problem that you're speaking of is breaking through that management ceiling. And we do exist, and we do count, but we will count only as much as we make ourselves be counted. So look at where we spend our money, because money talks and money gives a solution. What was civil rights all about? You broke the bus system. So let's look at where we spend our money and speak up, even when we start seeing ads that don't tend to include us in the pictures. Or you got to look to the last page of the ad to find somebody ad to find someone that looked like you. So I'd say look at where we spend our money if we want to start to impact right now. And we do spend a lot of money, even in these economic times. In terms of the
Office of Minority Health and
Office of Minority Health, the Office of Minority Health, as you heard this morning, has been elevated to report directly to the Secretary. There are individual offices of minority health at the agencies, including CDC, SAMHSA, HRSA, FDA, CMS, all of those agencies that for years may have started to do something and pull back, or started to do something again and pull back, or leadership change, but now you have it in statute that there will be individual offices of minority health at each of those key agencies. The only one that didn't go through was with regard to the Administration on Aging. Perhaps there may have been some decision that CMS doing Medicare and Medicaid could do that, but there indeed should have been one for Administration on Aging too. But we were doing good to get as much as we got in, believe me.
Thank you.
The National Center on Minority Health is now an institute. Keep in mind with all of this, healthcare reform is yours. If you help to make it be what you want it to be, it will indeed work a lot better. Health reform implementation in Georgia is not going to be health reform implementation in Florida, Alaska, Connecticut, you name it. You have to make health reform be what you indeed need it to be. So do get involved at your state level, through your governor, through your Office of Minority Health, because a lot of offices within the states do have offices of minority health. Help them to do a better job for you and your community. Look at your church. Look at the volume there and all that power there. Look at all the power in this room and what you can go back and do. The reporting to the Secretary, the individual offices, the elevation to an institute will only make the critical differences if we help make that critical difference. They're counting on us, as they should. They are on these panels. When the government agencies come, they can only say so much. Most of your questions you almost have to put in your professional judgment. Can you answer? But even with that, they may go back to the offices and get some type of reprimand. Ask yourself, why shouldn't funding for the Office of Minority Health be tripled? They can't get the job done without tripling it. Tripling it may sound like a lot, but believe me, it is not. You're talking about roughly maybe $130-some million. But look at the job they have to do across every community of color. And from time to time, there have been threats on that office to broaden the definition of health disparities, to move away from minority health, to do everybody's health. If everybody's health is being done by HHS, look at the volume of that budget. Now zero in on minority health, and it's been roughly, if you could do it in constant dollars, it would probably turn out to be about 30 million. But they don't tend to do budget tables in constant dollars anymore. And we need to request one, and that we will do. So again, those offices will be as strong as you help make them. Look at the Institute now. They need to be, the National Institute on Minority Health, Health Disparities needs to be on same footing with the National Cancer Institute, the National Diabetes Institute, all the other sister and brother institutes. And there's no reason why they shouldn't. That comes with funding. After an appropriations bill is done, what do the agency folks go back and do? They look at the budget and see how much they got. That budget is their power in that decision-making process. So again, those are your offices, your Institute of Minority Health, your health reform. Know as much about it as you can, and what you don't know about it, feel free to ask. And if they don't get the right answer to you the first time, ask it again. Use healthreform.gov. Use regulations.gov. Comment on the various opportunities that are out there. Even if you think your comment is late, it's your government. Send your comment anyway and expect an answer. I'd better stop at that.
Okay. And we have some other comments that some of the commission members want to make, but we wanted to go to Dr. Fagut's question.
Hey, thank you, Congressman. Thank you for your continued and sustained leadership, Congressman Christensen. I think Congressman Louis Stokes would be very pleased with this panel and your leadership of Brain Trust, and to have Fredette still with us. Thank you, Fredette, for all that. Our president, Dr. Edwards, has really told you where we are with the NMA. I'm Walt Faggett. I chair the Council of Medical Legislation in concert with the Health Policy, and I really work for Brian Soji. That's another issue. My question here, though, I had a patient last week, and I'm glad Everett Moon Park is right here. Again, lovely 22-year-old with real problems, had a lot of family conflict, but anyhow, she required hospitalization. The mental health system is broke. I had no place here in the state of D.C. We have a real broke mental health system. We have no adequate substance abuse treatment. The public health system is absent. And I think this is true around the country. The panel has done such a marvelous job. The thing that was missing was including mental health. I think this is so often at these meetings, we talk about all the collaborations left out, NIMH, SAMHSA, these kind of things. So I think it's important as we go forward, and I know we don't have time today, but I would ask that we now begin to talk about mental health parity. The whole Affordable Act bill left out mental health because it's too tough to handle. So I think we, as concerned providers, legislators, and decision makers, need to be about making sure that every time we say something about health, mental health, substance abuse treatment are part of it. Thank you.
That's right.
Thanks. Go right ahead.
Dr. Faggett, I definitely agree with your sentiments. It took a long time to get oral health on the radar screen and to get parity and to have people understand the linkages between oral health and systemic health. One of the things I wanted to comment on, to carry on Dr. Smedley's comments, the NIDCR, the National Institute of Dental and Craniofacial Research, has since 2001 provided approximately $7 million for health disparity centers, and they're located at Boston University, San Francisco, University of Michigan, University of Washington. These centers partner with academic health centers, state and local health agencies, community and migrant health centers to focus on patient populations and issues surrounding health disparities. So I wanted to be sure to make that link. And also for our country's national security, it's important. The National Institute of Dental and Craniofacial Research was one of the first 3 established NIH centers, and it was established because we couldn't send our troops to war because of oral health care problems. So I do understand the need for including mental health as well as dental. Dr. Faggett, to talk to you.
Thank you. And in partial response maybe to the previous question too, our HBCUs have large schools of business with marketing, finance, divisions and so forth. And I think maybe one area that we can focus on is on our HBCUs and all of the minority serving institutions that have schools of business, and try to point them in the direction also of becoming a part of this healthcare reform process. We do need the managers. Anyone else?
Just very quickly.
Or anything that you...
Walter, in your piece that you mentioned, I would say put that on the new and upcoming mayor's agenda in terms of the 3, mental, oral, and physical health. And there is funding in, with regard to the other lady, there is funding in the health reform bill that addresses HBCUs and other minority serving institutions.
Well, What Dr. Faggett brought up on the issue of covering mental health brings up another question that actually I don't have an answer for, but it really concerned me. Just recently I was at a meeting, and this was with a lot of other employers and their human resources directors. And what was stated was that in their human resources, they have decided with the new healthcare reform and the fact that they've got to cover all of their employees, that one of the things that they're going to leave out in terms of coverage is mental health. When I heard that, it obviously very clearly alarmed me as a total healthcare person and in primary care, and recognizing that it's been for a long time that I've had to deny whether or not I was seeing a patient because of mental illness, because I wouldn't get paid or reimbursed for that. Now to say that they're going to leave those kind of services out among employees, I'm hoping some of our panelists here, my colleagues here, might try to address that, but it very much concerned me, and I'm not sure where we can go in terms of better addressing that across the board.
And I actually just wanted to add something. I know we'd actually spoken about this last year during the whole negotiations, and one of the things that's interesting to note was that during the negotiations, when they were divvying up, especially in the Senate, the different issue areas, mental health was the one that nobody wanted to address. They didn't want to take it. And you see that really reflected in the bill. But there are provisions in there, I have to say, around workforce with increasing diversity in the mental health professional workforce. I think those are actually the most robust diversity requirements out of all of the health professionals. So that was a good thing. And then there are grants in there as well for mental health professionals to work with other health professionals. And then there are grants in there for students, for schools, health profession schools, to work and collaborate with each other. So there's that emphasis on collaborating across the professions within there, and they have those grants. But I agree with you that it's very limited, and it's something that I think that we all do need to address as we're moving forward to make sure that the very few mental health provisions that we secured are carried out.
Great. Go ahead, Yodelman.
Not speaking directly to mental health, but more the workforce provisions in general, I do encourage folks to become familiar with them, because most of the workforce provisions, whether it's new grant programs to institutions or loan repayment to students or however they're structured, do have language in the statute, in the law, that talks about the need to think about culturally and linguistically appropriate services. But it's one factor. It could be a very robust factor if it's implemented well, and it could just be a checkbox that no one really pays much attention to. So I think, again, as many of you have brought up the workforce issues, we really need to look as those provisions are being implemented, as the grant programs are being developed and the proposal systems being developed, that we really make sure that we take, again, where we have that opportunity because there's statutory language, and make sure that it's implemented in a way that really meets and addresses the needs of the folks that we're talking about. So that if there is a grant program going out, that there is really strong training on how to provide culturally and linguistically appropriate services. It's not just 1 hour, but it's embedded throughout an entire curriculum of a school that's getting a grant. Or that students who are actually going to get some of the loan repayment are committing to serve in certain communities, or are educated about how to work with an interpreter. How do you work with different cultural issues, et cetera. So again, it's a strong opportunity. We have to take advantage of it to make sure it works for our benefit.
And I just actually want to piggyback on that too, because it's a really good point, and I know Fredette said it earlier about the appropriations process, because many of the workforce provisions in there, the grants, those are discretionary grants. And there might be 1 or 2 mandatory grants in there. But as far as discretionary goes, we need to continue to advocate for funding for those. So yeah, we secured the authorization, but there's no funding currently. And when you speak to offices on the Hill, they say, well, it's a very tough situation right now. We don't know if half of those are going to be funded. And then you hear on the other end that, if the House were to flip, God forbid, then the chances are even more limited. So those are things that you need to be aware, be vigilant about as we move forward. And even with the mandatory funding, I heard Ruth mention this earlier with Senator Johans in his amendment to strip out the Prevention and Public Health Fund, basically virtually eliminating it by $11 billion. There was $15 billion in there that is targeted to prevention programs. And a key part of that is the community transformation grants. These grant programs are basically what it says. They're to help community-based organizations to develop these programs that will help to reduce disparities. And if that program were to be eliminated, even though it had mandatory funding, there goes that grant program. So just be vigilant as we're moving forward. Even if it's mandatory, you still need to be aware.
Right. There was a lot of work that went on behind the scenes to make sure that that amendment did not pass.
This is my very first time attending the conference, and I thank all of you for the work that you do and for the information that you are giving me so that I can take back and distribute to everyone that I come in contact with. But I have a one specific question. We've talked a lot about the workforce, and we've talked a lot about the pipeline. My question is about those folks who are at the end of the pipeline, those older adults who are at the end of life with end-of-life issues and older adult care. So if you could help me, give me information that what specifics in the provision of the healthcare law will assuage some of the concerns that older people have about this healthcare law. What can I do as a geriatric nurse to fill in the gaps of their information? What should I be telling them? What information should I highlight to assure them that their adult care, older adult care, and their end-of-life care, all those issues that take them to the end of the pipeline, what information can I take back to them? And I'd appreciate that.
Somebody answer that? Wow, that's a tough one. What's the name of the program? Is it Choice? We have a
class.
We're going to have a presentation on the Class Act, which I think will be helpful to you as well. I don't have a specific answer for that question, though. And
can I?
And I know our previous, the lady that asked the previous question is very much interested in that issue as well, from Vitas.
What I wanted to say is that help them to remember that they have choice, 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 that the plug cannot just be pulled, that it may not look as clear as they may think in the black and white print, but they do have choice, choice, choice. And on healthreform.gov, it's just too bad we've gotten to a point where everything is so much internet. It's a good and a bad thing, because not everybody has access.
Right.
But there is choice there. There is opportunity there. There are provisions there related to caregivers. There are provisions there related to in-home health. And there's also help there with regard to community health workers, health literacy, the mix. Keep in mind, every component that's in those bills had to have somebody to fight for it, because there was no open door policy, especially as it related to racial and ethnic health disparities. The House bill was definitely the better bill in terms of racial and ethnic health disparities. When we got to the Senate, there were major gaps. In fact, there was no Office of Minority Health Elevation or offices or National Institute of Minority Health. Senator Cardin and his staff, Priscilla Ross on that end, and at the state level, as we've talked about power, at the state level, Delegate Shirley Nathan Pulliam of Maryland helped us tremendously in getting those in. There's a fight always along the way, but there are provisions with regard to choice, choice, choice.
I think also, first of all, the expansion of Medicaid and just that the assurance of having insurance coverage ought to be something that they can look forward to. The medical homes and the accountability care organizations that are really patient-centered and where there's a team and comprehensive approach to health care, those I think would be something that can be reassuring to them as well.
Something else that should also be mentioned, literally I was having a conversation with my mom this morning who came to town to participate in the conference about some of the changes in her insurance that she is experiencing as she's just transitioning into full Medicare. She learned to her great surprise that some preventive services that she had under her prior insurance, she would no longer be receiving under Medicare unless she already had the condition. So some of those, services basically would not be covered under Medicare. That will no longer be the case. So it's not that Medicare will only provide you with coverage for conditions that you already have, but for certain key preventive services or preventive screenings, they will now be able to offer them to you without any kind of coinsurance or copay.
I think it's important to, especially in light of a lot of the attacks that have been made against the bill, specifically referring to Medicare, that Medicare is really going to be strengthened through this bill. The providers will have a higher reimbursement, which will mean that more will be able to take Medicare patients. The donut hole that people fall into once they've paid, I think it's like $27.50 out of pocket, will starting to be closed this year with a $250 rebate. And there's several other, and just the fact that the solvency of Medicare will be lengthened by, I think it's about 19 years or so. But Medicare will be a much stronger program because of healthcare reform as well. Bruce?
And I would add one, you didn't ask about kids, but on an end-of-life issue for children, there's also an important provision on children's hospice. And, I think the current policy is pretty barbaric, is that if you go in, you can get no treatment whatsoever, and the law changes that. So there's also on the kids side a very important end-of-life kind of issue that, just put families in a horrible position before, and so that will be a change.
Question from the audience?
Yeah, Hybrid Medical Analytics from Houston. I want to get your impressions on genomics.
We're going to have a big discussion on genomics at the end of the day. We have Dr. Georgia Dunstan here from Howard University. I hope you'll be able to stay here for it. I don't know if anyone wanted to make a comment from the commission.
10,000 feet view, what do you think, just up the top?
Well, go ahead.
Dr. Dunstan may want to answer.
Do you want to make a comment at this point? Let me let Brian go, and then we'll pass the mic to Dr. Dunstan. Go ahead, Brian.
Well, I'm not a geneticist, but I think that genomics is certainly important. There are new breakthroughs occurring in genomic science. Dr. Dunstan will probably illuminate us on many of those things. One of the things that I think is exciting at NIH is that we're beginning to have a better interdisciplinary approach, that we understand genomics in the context of social environments, in the context of economic conditions. This is particularly important when you're talking about health inequities, because for too long there has been a myth that the health inequities that communities of color face are the result of bad genes or bad behavior. Neither of those is true. We need to have a much more integrative and ecological approach to understanding genes, gene expression. We need to change the culture at institutions like NIH, where for too long people have felt that they could solve health disparities by looking through a microscope solely, when in fact you have to turn that microscope around and study society and study inequality, racism, discrimination. All of these have health consequences. So I'm excited to see the next steps that are emerging through interdisciplinary research.
Thing before
Sure.
Dr. Dunstan. Just very quickly,
And we're wrapping up. We have
completely
about
agree with Dr. Smedley.
2 minutes.
But I also want to say that we have to understand that it's not an either or, right? And that that genes are an expression of our environment, and our environment is an expression of these social relationships. And that oftentimes there's too much emphasis one way or the other, but we have to recognize that our bodies are embodied, social expression. So that's, you asked a very big question that it's going to take a whole panel for 2 hours to answer. So I hope you will stay.
And Dr. Dunstan, we just want you to whet his appetite for staying around for the afternoon.
First of all, I was surprised, and thank you for the question. I'm sitting here listening. And genomics has changed the whole landscape. It has changed the whole landscape of medicine. And I like to say it's a view of biology and life from the inside out. And what we are dealing with now are the consequences of a whole way of looking at life from the outside in. Now, genomics comes and says, this isn't the way life works. And we're in that transition, and particularly with regard to this whole area of mental health. It is so exciting. Health disparities become an opportunity to really understand biology and to understand really how life works. And it forces us to even look at how we define life. And the whole area of mental health is going to be big because it's about behavior. And health disparities are about behavior. So we have to understand the biology of behavior, why we think the way we think, why we act the way we act. And we are biological beings that operate by laws that are being unfolded. And it is a lot about how we think and the role of thinking as a biological process. So I hope you will come and help us to look at the whole landscape has changed. And the problems that we are dealing with are largely a consequence of the way we look at life. So we will have to make some choices about whether we're ready to look at life differently, especially what we think about ourselves and each other.
Thank you, and we're at the end of this panel, and I hope that all of you have been greatly informed by our commission members, and through your questions and your comments, you've also helped us to focus in on some of the areas that we need to focus in on going forward. So let's give the commission members a big round of applause.